right, doctor. What's my problem?
Well, what you've got is ulcerative colitis.
Ulcerative colitis. I see. What exactly is ulcerative colitis?
Well, basically, it's one of the major inflammatory bowel disorders in which the primary process causes mucosal edema, friability, and contact hemorrhage. Exacerbations are frequent. Treatment reduces their frequency and duration. Surgery is not contraindicated. Late sequelae include neoplastic change. I'll see you in 6 weeks. Were there any questions?
Nope.
You sure?
Yep.
Fine, then I'll see you in 6 weeks. Bye-bye.
Bye-bye.
It's one of the major inflammatory bowel disorders in which the primary process causes mucosal edema, friability, and contact hemorrhage. Exacerbations are frequent.
Well, as it happens, I haven't got ulcerative colitis. And, of course, doctors don't really talk like that, but sometimes that's what they sound like. Because if a doctor tells me there's something wrong, well, when I get home, I realize I haven't understood everything that the doctor said. And there are always some questions that I should have asked, but for some reason didn't. In fact, I always feel I'd like an instant replay of what the doctor told me, so that I could really take it in and then have some time to think so that I could ask the right question. And that's exactly why we've made this video. So that you can hear from Rob Buckman over there, who's a proper doctor, a hospital specialist, all about ulcerative colitis. And then, when you've heard what Rob's got to say, if there's anything at all that you don't understand first time, you can just replay it. And if necessary, replay it again, and again, and again, till you really feel you've got it. And then you can think about it, and then you can start to jot down on a piece of paper the questions that you want to ask your own doctor. So, let's get started. Rob, take over.
Well, first of all, let's look at what I'm going to be telling you about ulcerative colitis. First, what is this disease all about? Then, what are the main symptoms? Then, what causes it? Next, how is the diagnosis made? What's likely to happen next? What treatment is there? What drugs are used? What about surgery? And finally, where can I get more information or help? Those are all the things that we'll be talking about. So now let's go back to the beginning and ask, what is this disease all about? Well, ulcerative colitis is a condition that's not actually very common. And what happens is that for some reason we don't fully understand, the large bowel, or colon, becomes inflamed. That's where we get the name from. Colitis just means inflammation of the colon. Don't worry, I'll tell you exactly where the colon is and what it does in a moment or two. Now, unfortunately, ulcerative colitis is a condition that usually goes on for a long time, at least for many months, and often for many years. In other words, it's a chronic condition. Chronic just meaning long-term. But that doesn't mean that you've got the symptoms all the time. They come and go. Sometimes they get better for a bit, then worse for a bit. The good news is that ulcerative colitis can usually be controlled, so that although we can't often cure somebody of ulcerative colitis so that it goes away forever, we can use medicines to make the symptoms easier to put up with when they do flare up. And here's one more important point. Sometimes patients with ulcerative colitis may need surgery. Now, before we go on to discuss the symptoms, let's go back to basics for a moment. I'm sure we need to, and have a quick reminder about where the large bowel or colon is and what it does. This is a very simple diagram of the human gut or gastrointestinal tract. Of course, the mouth is at the top end here, and here's the order of things. The food leaves the mouth, and it goes down the gullet or esophagus into the stomach. Then it leaves the stomach and goes into the duodenum, where the process of digestion begins. And then it goes through the 20 feet or so of the small bowel, that's this stuff here, And it's called small bowel because it's small bore, and that's where the nourishment is absorbed from the food into your body. And then it goes up, along, and down the large bowel, which is, of course, larger bore, and it's during that journey through the large bowel that the water is absorbed from the contents of the bowel and where the contents are turned into normal stool. Now, in ulcerative colitis, for no known reason, the walls or the lining of the colon become inflamed. So let's straight away see what that inflammation looks like. First of all, to compare it with normal bowel, this is what normal colon looks like when it's seen from the inside. The lining is sort of nice and pink and flat. But when you get colitis, the lining becomes red and bulgy and swollen. And it also produces a lot of mucus, and it has a tendency to bleed easily. And that explains how you get the symptoms of colitis. In the early stages, you may have no symptoms at all, because your bowel can cope with a small amount of inflammation quite easily. But when there's more of it, meaning that more of the large bowel is inflamed, then the inflamed lining does begin to bleed, and that produces something that you'll have noticed, which is some red blood on the stool. So in the early stages, the stool itself might be completely normal, or you might actually be a little constipated, but there may be some red blood on it. As the illness gets worse, and that means more inflammation in the large bowel, what happens next is the bowel can't absorb fluid from the stool in the usual way, and so the stool becomes more watery. And that's why the next symptom is diarrhea. And because the bowel has to move more to cope with that diarrhea, and because the bowel wall is inflamed, moving it more can stretch it and make it tender, and that means that you're quite likely to feel some cramping pain with the diarrhea. Unless it just happens that this last part of the large bowel is involved. Then you get a slightly different symptom. Instead of, or as well as, that cramping pain, you'll usually notice a sense of urgency when you need to have your bowels open. And all those symptoms that you feel or notice are caused because of that inflammation in the lining of the bowel. Now, naturally, we need to be able to talk about how severe that inflammation is. So here are the terms that doctors use. Doctors call it mild colitis if there's diarrhea so that you have your bowels open 3 to 5 times a day for more than a week, or if you have small amounts of bleeding or mucus on the stool. Although, of course, it does not seem mild to you, particularly if you've never experienced anything like it before. We call it moderate colitis if it's a little worse than that, with more than 5 stools a day. Now, so far, I've been talking about the symptoms that you may notice in your abdomen. But if there's a lot of inflammation going on, you might also feel ill in general. And those general symptoms are these. You might feel tired and lacking in energy. You might also get fevers. You might get weight loss and loss of appetite. And those 4 are the general symptoms. And you might get some of those along with the local symptoms. That means the symptoms in your abdomen. Now, most of the time, most people with colitis will notice just the milder symptoms, and they can get worse from time to time, plus or minus some mild general symptoms. But sometimes, unfortunately, it's not all that often, the colitis might get much worse. And much worse means that you might get severe bouts with very high temperatures, feeling very ill indeed, and constant loose, bloody stools. And that means you may need to come into hospital. Of course, nobody wants to. But if you get a severe bout like that, it's very important to accept that it may need hospital treatment for a while. So that's the general picture. Mild colitis is quite common. Moderate colitis is less common, and severe bouts are fortunately quite rare. Now, there's one other point I want to tell you about those symptoms, and that's to do with symptoms in other parts of your body. Occasionally, ulcerative colitis can cause symptoms in parts of your body other than the ones I've already mentioned. for some reason that we don't fully understand, the colitis can cause inflammation in the joints, in other words, arthritis, or irritation of the eye, or irritation of the skin in the form of distinct and recognizable rashes. None of those mean anything particularly bad. But if you do get any of those problems, please be sure to mention them to your specialist, as they may be associated with your colitis.
Forgive me for interrupting, but I do want to remind you, if you're not completely clear about what you've just heard, just rewind the tape and go over it again, and again if necessary. After all, this is quite difficult stuff, and it may be all the more difficult for being new and for being about you, which can be anxious-making. So don't be shy about replaying the tape as often as you need.
Well, as regards the causes, there is a simple and clear answer. We have absolutely no idea what really causes ulcerative colitis, honestly. There have been dozens of theories blaming it on diet, on infection, or on stress, but none of those turned out to be true. At one time, psychological factors were thought to be important. When I was a medical student, I remember there was a fashion for identifying the so-called typical colitic personality as an obsessive, fussy, body image conscious kind of person who was very prone to getting colitis. That turned out to be complete nonsense. The so-called fussiness wasn't the cause of the colitis, it was the effect. I mean, 5 stools a day, plus pain, plus urgency, plus a fear of being incontinent, plus tiredness, and anybody would find they were being really careful about their bowel habit. It was absolutely the correct and normal way to respond to very difficult symptoms. The only thing we do know is that sometimes there are some genetic factors involved. In other words, the disease can run in families. We also know it's more common in people of Jewish origin, but we don't know why. So as regards causes, and this is really important, it is nothing that you have done, or anything that you've got from your diet, or from the environment, or anything like that. As far as we know, ulcerative colitis is just pure bad luck. So, how is the diagnosis made? That means, how do the doctors know that it is ulcerative colitis that you've got and not just something you picked up on holiday somewhere, let's say? Well, that's very important. And the tests that are needed to make the diagnosis will probably already have been done by your specialist, and that's the person most likely to be looking after you. Some of those tests will have been done to make sure that you haven't picked up a bowel infection, for example, on holiday. And those tests are usually done quite simply by sending a sample of your stools to the laboratory. Now, that test will tell your specialist what the diagnosis isn't. You need other tests to tell what the diagnosis is. Basically, the main test to make the diagnosis of colitis depends on looking at the bowel itself, using a sigmoidoscope, and that's a tube with a little light bulb at the end of it that allows the doctor to look directly up into the last part of the large bowel, into the sigmoid colon. That's what it's called. Or you may have had a colonoscopy, in which the doctor uses a longer, flexible tube that allows him or her to look all the way round the colon. The important object of the exercise is to see what the bowel wall looks like, and to take a piece of it and to send that piece to the laboratory to have it examined under the microscope. That process is called a biopsy. And it's the biopsy that shows that it's inflammation you've got and not something else. Now, apart from the sigmoidoscopy or colonoscopy and biopsy, there's another test that might be done, but it isn't always needed, to find out whether what you've got is ulcerative colitis. And that test is a special X-ray called the barium enema. In the barium enema, some liquid which shows up white on the X-ray is run into the large bowel just like an ordinary enema. And what we've got here is a normal barium enema. It's just like the diagram, really, showing the normal colon, which is nice and wide, with these characteristic little markings. In ulcerative colitis, the barium enema looks completely different. And what you can see here is that the colon is much narrower and that the edges of it look fuzzy. And that fuzziness is the ulcers of ulcerative colitis. The point about colitis is that it's a long-term disease. It's chronic, and it fluctuates, getting better and worse. And that means that regular sigmoidoscopies or colonoscopies, and maybe even repeats of the barium enema, might be necessary to assess how things are getting on with you personally. I promise you, it isn't just sadism on the part of the medical profession. It's really important to keep a close eye on your particular condition so that the treatment can be adjusted as needed. Obviously, it'd be much nicer and much more convenient for you and for the doctor if it could all be done with something simple like blood tests. But unfortunately, blood tests just aren't sensitive enough. And so regular sigmoidoscopies or colonoscopies, and perhaps even barium enemas, are often needed. So far then, we've talked about what kind of disease ulcerative colitis is, how it's caused, its symptoms, and how the diagnosis is made. And in a way, that sort of brought us up to where we are now. What I'd like to do next is to talk about the future, what might happen next, what treatment can achieve, how you can get more information, things like that. So let's start with what's likely to happen next. As we've said several times already, ulcerative colitis is a long-term problem, and it doesn't often disappear quickly and forever. And also, it's a coming and going, fluctuating disease. And that means there'll be periods, and they may be quite long, in which the colitis doesn't cause you any trouble at all, and other times when it does, and that's normal. That's what the condition is like. So when the symptoms come back, it isn't because of anything you've done wrong or that your doctor has done wrong. But there are some things to watch out for. And again, this is not to scare you, but it's to help you understand why it is that doctors are so vigilant about ulcerative colitis and why they want you to keep coming back for follow-up visits, even if that means repeating the sigmoidoscopy or colonoscopy. And that is, if the colitis has involved the whole colon for many years, then there is an increased risk compared to the general population of bowel cancer. For that reason, nowadays, specialists recommend regular examination of the bowel and the taking of biopsies. So that way, if it happens that your colon does develop a cancer or precancerous changes, they can be dealt with quickly and can be caught at an early stage, which with colon cancer really makes a difference. But here's the message. That's a rare event. When it comes to predicting the future, for the great majority of people with colitis, the best guide is how your particular colitis responds to treatment. So let's talk about that next. Well, as I've said, sadly, colitis is not usually curable in the usual sense of that word. There isn't a treatment that you can take that will make it go away, never to come back. And that means that in the majority of cases, you'll just have to live with the condition. But treatment can still do a very great deal to reduce and control the symptoms. And the first step in treatment consists of things that you can do for yourself. Particularly if you're in the younger age group and still growing, it's recommended that you really take good care to eat a wholesome, nourishing diet. Nothing particularly fancy, but just try to stick by the national guidelines for the recommended daily diet. Sometimes patients notice that milk makes the diarrhea worse. If that happens with you, try reducing or cutting out the milk that you drink. For almost everybody, and for almost all of the time, treatment usually means treatment with drugs. It may be quite helpful for you to be a little bit familiar with the medications so that you and your doctor can understand each other. I should also say, I'm going to use just the generic names of the drugs, their proper names, as it were. Different pharmaceutical companies may produce the same medication, but they may put their own brand names on it. For the mildest episodes, and that's the great majority of patients, you may need only antidiarrheal medicines. If your disease is worse at any time, or if the antidiarrheal medicines don't work, then your doctor might prescribe other drugs to reduce the inflammation itself or to keep it down when it's down. The commonest medications that do that are the steroid prednisolone and another medication called sulfasalazine, or its newer relative, mesalazine. But perhaps the most important point about remissions and keeping people in remissions is that some people need to keep on taking the medications even though they feel perfectly well and the symptoms have disappeared. So please listen to your specialist and do what she or he says. Now, sometimes controlling the colitis may need you to give yourself enemas. And basically there are two kinds of enemas, water-based and foam-based. And I'll just show you how you do them. Basically, this is a water-based enema. All you do is warm it up in the sink to lukewarm body temperature, snip the nozzle off here, lie down on your left-hand side, insert the nozzle gently into the bottom, and then gently squeeze the fluid in. Then roll onto your tummy for 10 minutes, and that's it. Or the enema may be foam-based. What you do is load the syringe by pulling back the piston like that, putting the foam into the syringe that way. Again, lie down on your left-hand side, gently insert the nozzle into your bottom, and push the foam in, and that's it. The types of enemas used most commonly in colitis usually contain the steroid that I've mentioned already, prednisolone, or perhaps some other drugs. Now, giving the medication by enema, although nobody likes doing that at first, is actually a very efficient way of giving the drug, because the medicine gets to the area of the problem where you need it and not anywhere else. And it's a way of avoiding the major side effects of taking the same drugs by mouth. For the same reason, actually, sometimes suppositories can be used as well. The really important thing to remember here is that it doesn't mean that your disease is worse. It simply means that most of the disease is limited to one place and it's accessible by enema, and that is not bad news. One further quick point about treatment, and that's to do with treatment during pregnancy. If you're female and become pregnant, congratulations, and don't worry. You can continue all your medications during the pregnancy. They won't harm the baby, and it's very important to try and keep the colitis under good control. Almost always, everything works out just fine for the mother, for the baby, and for the control of the colitis. So those are the basic forms of treatment: anti-inflammation medications and sometimes medications by enema or suppository. In most patients, that keeps everything under control, but just occasionally, that isn't enough, and your specialist may want to discuss surgery with you. Now, there are some situations in which surgery might be an important option, but whatever the circumstances, it is quite a major decision and it needs detailed discussion. Usually, if surgery is necessary, it means removing the whole of the colon. And quite often that means bringing the end of the small bowel here to the surface of the abdomen, to the skin in other words, to make an opening known as a stoma. And when a stoma is made at the end of the small bowel, or ileum, the two words come together, and that's why it's called an ileostomy. And there's another video in this very series about stomas, what they mean, and how to look after them. In some patients, it might be possible to remove the colon in a way that doesn't need an ileostomy. This is known as the pouch operation, but it might not be suitable in every single case. But those are the main types of surgery that you're most likely to be discussing with your doctors. Now, very, very occasionally, surgery has to be done as an emergency. If the colon has actually perforated or developed a hole in it, that's very rare. Or if it's simply so inflamed that the patient is seriously ill and not getting better with medical treatment. Those are true emergencies. But in all the other circumstances, there's much more time for the decision, and it can be discussed in detail. information is actually an important topic in itself. And that's one of the reasons that we hope you'll contact the organizations that we'll be mentioning in a minute. The unknown is always a bit frightening. And the more information you've got, the more secure your decisions and your choices will be. And the better and the less worried you'll feel. With ulcerative colitis, there are actually quite a few associations and organizations specifically set up for people like you. And I must say, they're really helpful and supportive. If you look at the package that this videotape came in, you'll find a list of the important organizations with addresses and phone numbers on the insert that comes inside the box. So if what you're thinking is, what can I do for myself right now? One of the answers to that question is, make contact with one or more of those organizations and get the up-to-date information that they make available. It's really worth it.
Well, I'm sure it is, because what struck me so strongly listening to you now is what a major commitment patients have to make to looking after themselves. I mean, they've got to get the treatment right, they've got to tell the specialist what's going on, and they've got to be involved in all the discussions. So they have to take a lot of responsibility.
Oh, I mean, they really do. And to keep ulcerative colitis under control, you've got to overcome the normal feelings of embarrassment that we all have, feelings of, I'll leave it all to the doctor. And it's actually a matter of facing these apparently awkward and embarrassing things and learning to do them well in order to keep well.
Mm. And how long does it usually take someone to get used to it all?
Oh, well, it's not all that long, actually. I mean, it may be as little as 4 or 5 outpatient visits. But wanting to do it right is most of it. Potentially, ulcerative colitis can be quite nasty. And that means you have to be prepared to make a real commitment in order to keep it under good control.
Well, I hope you've got some useful information from this video, and I don't want to sound repetitive, but please do play the tape again and again as often as you need until you feel you've really understood it.
One other hint, as we said at the beginning, none of us can remember what we hear or what we want to ask when we're at the doctor's. That's a fact of life. So why not jot down the important questions or the points you're worried about on a bit of paper and make sure you go through the main items on your list while you're actually there with the doctor. It really helps.
And finally, we both hope you'll also write or phone the organizations that are listed inside the cassette box so that you can get more information. Understanding what's going on always makes things better. Bye-bye.